think the hip fracture model is an excellent model for showing what can be done with the frail elderly population. So I think we can extrapolate from the advantage of this program to what should be done to the aging population in our hospitals in general. And in speaking about how you can keep people at home, of course a lot of these issues are outside the purview of the hospital sector. Now, the aging population has been referred to as the silver tsunami, and it's a worldwide issue. And interesting enough, it's in the third world the aging population is growing most dramatically. However, we certainly see it here, and I think with the analogy of the frog, well, if you put it in hot water and then gradually warm it, it won't jump out. But if it's too late, it jumps into hot water and jumps out again. I would suggest that our healthcare system is very much reaching a very hot level, and we're frogs in it, and we haven't had the sense either to jump out or to change things dramatically. We have to look at chronological versus biological aging. And aging isn't a disease, but certainly as one gets older, one does pick up a lot of degenerative diseases. And we've got this argument that's been going on for many years now. Are we going to see what Bernard Isaacs referred to as the survival of the unfittest, or are we going to see a much healthier model of aging? And I think we're going to see a healthier model, but that's going to my mind, add more problems to the healthcare system rather than less. Because to keep them healthier, certainly the drug companies are going to do very well, because from the point of view of hip fractures, we're going to want people to be on medications to prevent osteoporosis. As cognitive enhancers improve, everyone's going to be on those. So one aspect of the aging population that's going to be very healthy for the pharmaceutical industry. With regard to the attitudes of healthcare professionals, I think these may be best described by an acronym which was mentioned in The House of God, which was a book about 20 years ago, talking about a teaching hospital in Boston. And the acronym then for the frail elderly was GOMAS, which stood for Get Out of My Emergency Room. And I think things haven't changed all that much. Now we're concentrating on moving them through the healthcare system as quickly as possible. Now this is only going to lead to a revolving door unless we put more resources to prevent them coming to the hospital in the first place, or keeping them in the hospital, out of the hospital, once we've discharged them. Now the emphasis is shifting, fortunately, to chronic diseases, and I think that's all to the good. But if you look at any of the literature about these various topics, everyone's talking about they're going to face an epidemic in that particular chronic disease. And the recent rising tide from the Alzheimer's Society emphasized dementia, but also if you look at these various various studies on a fractured hip and guidelines, they talk about osteoporosis as an epidemic. But the key thing is that these conditions don't occur in isolation, and that in the frail elderly, they're going to have several, if not all, of these conditions. And we moved away from the acute model to a chronic disease, but we've got to look at the combination of those, and that in essence is how geriatrics responds to this multiplicity of cognitive diseases. Now these are the complications. I don't want to get into too much detail to the clinical issues, but they are very frequent, and obviously delirium, venous thrombosis, urinary problems and pneumonias are common. Decubitus ulcers is something that we can do something about, and Dr. Hurdy showed some of the differing figures, but those are things that are preventable. malnutrition and dehydration can be problematic, and worsening of the comorbidities. And if you're looking at favorable outcomes, the pre-morbid condition is a very good factor in deciding that. And if they've got several chronic conditions, then their chances of doing better are decreased. Constipation is something that's picked up in the Scottish guidelines, and they're always more practical in their approach. And that simple things like that are often overlooked. And it's the very simple things that need to be done well to decrease the ALC numbers and to get people back. And in a very busy hospital, when people are rushing to deal with emergencies, it's these simple things that may be overlooked and lead to bigger problems later on. Now, we know everyone's so busy in hospitals, and as I was saying, a lot of these factors of managing these patients are very straightforward and simple. And that's why from Yale they developed this Hospital Elder Life Program, HELP, which is dependent on volunteers, and they take part in these various activities to assist in the management of these patients. Also published on their results that did show great improvement in clinical outcomes, and nursing education and retention were enhanced, and patient satisfaction was enhanced. There was improved quality of care. So it does work. Now, I think that aging at home, I think, is a key issue. And the move towards family health care teams, I think, is going to be an important factor in helping keep the frail elderly away from hospitals. Physician home visits, this has always been a key factor in the National Health Service. All family physicians are accountable to their patients for care all the time, and have an accountability to do home visits. This has decreased over the years, but still in those over the age of 75, it's the provision of home care. I think that too is key. I understand, my social worker was saying the other day that the CCACs are now moving towards some different way of focusing on the elderly, which will provide help. But again, you can, if you're wealthy and elderly, there's no lack of support available. But if you're dependent on our system, then you run into difficulties. I think this was an article from Andre Picard a few days ago about this whole issue, so I think it's beginning to attract some public attention, not before time, because we really are going to be overwhelmed. And I was very disappointed about the Romano report a few years ago, and I wrote a paper about it and so across, because there's only one paragraph about aging in it. And it said, not to worry, European countries have got aging populations and they're doing very well. We don't want to make decisions too quickly. We're going to have a healthier aging population. Don't worry about it. Forgetting that in Europe they poured in resources to the aging population and community services for many years, and they're still topping those up and trying to address them, whilst we have done very little. So really, in conclusion, we have a major issue here with the aging population. It's not insurmountable. The hip fracture program is an excellent example of what can be done with frail, elderly, delirious patients. And we need to expand that to other aspects of healthcare. But we can't do it all within the hospital system. If there isn't a balance with resources being put into the community, we're really going to be boiling like those frogs in the hot water. Thank you very much.